So, so welcome to week 7. Sorry, I had to count my head, figure out which week we were in. So week 7, we're going to do 2 chapters this week. We're also going to have a couple discussion questions and a couple Kahoots. You guys will take a break and then you'll come back for your quiz. So please remember that you have to come back for your quiz. If you're not here at the end of class, you won't be able to take it. And then if anyone has any questions, if they want to go over their exam with me or anything like that, please let me know. Several of you have scheduled appointments, but I'm happy to go over the questions that you missed. And then I just want to give a shout out to anyone that comes to the exam reviews. I think they're very helpful. I strongly encourage you to come to either mine or Dr. Bogart's. There'll be another one next week because your third exam is going to be on during week 9. So unless you guys have any questions, I'll go ahead and get started with the material for this week. But I'll give a second. If anyone has any questions or any concerns about what's going on in class, let me know before I start this week's material. Okay. So we're going to start out talking about conditions, blood conditions, blood forming agents, lymphatic system. So I share the PowerPoint slides. If somebody is having a hard time omitting them, or if you have any questions, I'm happy to send them in different formats, but hopefully everyone has them. So you know, some basic information about blood. It's red blood cells are formed in the bone marrow when we're younger children. It's really just the long bones that the marrow in the long bones that produces the red blood cells, but that starts to change as we get older, and other bones in the body start producing red blood cells. And this hormone here, so erythropoietin is a hormone. It's regularly produced by our body, and it regulates the production of red blood cells. This is also something that there's a synthetic version. So if someone is not able to produce red blood cells for some reason, if they're having a problem with their bone marrow, this is a medication that is given commonly to patients that have problems with their bone marrow, and it helps them produce cells. And it's the synthetic form of the hormone that our body produces naturally. So in addition to the bone marrow and the blood cells produced by the bone marrow, there's also the lymphatic system, which is the system that drains regions of our body. It's very important for the immune system. It's where antibodies are produced, and it includes both lymph nodes and then the spleen. The spleen is the largest organ in the lymph system. So you know, the spleen kind of brings pathogens and cells that fight pathogens together, and they produce a specific type of white blood cell called lymphocytes. And then if things go wrong, if for some reason, sometimes when patients are sick, or if they have other conditions that cause small blood vessels or small clots to form in blood vessels, and blood doesn't move well through the spleen, they can have an enlarged spleen, which is called splenomegaly. So, and sometimes patients they'll have so many problems with their spleen, they'll actually have to have their spleen removed, which then obviously affects their ability to fight infections. So when we talk about blood, we talk about 2 main components. There's plasma, and then there's what's called the formed elements. So plasma is mainly water. It also includes things like albumin, gamma globulin, different proteins, hormones. And then the formed elements are going to be the different types of blood cells that you think about. So does anyone know what an erythrocyte is?
Is red blood cells.
Red blood cells.
Red blood cells.
Very good. And these other 2 were given to you. So leukocytes are white blood cells, and then thrombocytes are platelets. So I would know these 3 terms. They're used interchangeably. So you should definitely be able to recognize like the medical term and then the layman's term for red blood cells, etc. So erythrocytes are red blood cells. They carry oxygen throughout the body. Does anyone know the name of the protein that is bound to red blood cells that then carries the oxygen? Is the red blood cell? Yeah, hemoglobin. Hemoglobin. Very, very good. So when we're talking about anemia, we're going to be talking about hemoglobin and red blood cells, and the shapes of those different cells have a lot to do with how patients are able to transport or not transport oxygen throughout their body. So anemia, just in general, is a reduction in the amount of hemoglobin. So since hemoglobin is bound to red blood cells, it can be related to your red blood cell count, and then it can just be related to your hemoglobin. They're not necessarily the same thing, but anemia in general is a reduction in your hemoglobin level, which is the protein that carries oxygen. So it kind of says it here, but you can imagine if you don't have the enough oxygen carrying capacity, you're not going to feel very good. You're going to be weak. You might be pale. And then the dyspnea, short of breath, and congestive heart failure. What do you guys think about that? Why do you think having a low oxygen carrying capacity would cause you to develop congestive heart failure or shortness of breath?
Because
Not
the heart
enough
is not
oxygen
getting
to
enough
the
blood
heart,
flow and
oxygen to the heart.
oxygen.
Yeah, you guys are 100%, you're on it today. So right, so if you don't have enough oxygen, like you need oxygen for your heart, very good. Your heart is a huge consumer of oxygen, and also your target tissue throughout your entire body needs oxygen. So if you're not if you don't have enough or oxygen carrying capacity, your heart has to work harder to pump blood to your body, because it's going to, send more, like a higher cardiac output, more blood to your target tissue to compensate for the fact that the blood that is there doesn't have enough oxygen. So your heart works harder in order to get adequate oxygen to your target tissue when you have anemia. And that can ultimately lead to congestive heart failure. So iron deficiency anemia is the most common type of anemia. So you need iron to produce hemoglobin. So that's the most common type. It's usually diet related. You can also have like blood loss that then causes you to have iron deficiency anemia. And it mentions here cow's milk again. So does anyone remember at what age we start introducing cow's milk to infants and children?
1 year.
At 1 year.
1 year.
Okay, very good. So what, like, it doesn't have enough nutrition, right? It doesn't have all the nutrition as baby formula does, but it can also lead to GI bleeding. Their GI system isn't set up to digest cow's milk. So that can lead to microbleeding, and that can lead to anemia also. And also milk can block the absorption of iron. So there's a couple of different reasons that we don't want to give milk to babies, but one of the main one is that it can cause iron deficiency anemia. So we've kind of talked about this. These are some things that you would see for somebody who is anemic, and these are some of the tests that you would run. One that you might not necessarily think about is like looking at the stool for occult blood. So to see if they have some sort of microscopic tear or GI bleed that could be causing their anemia. So, and we briefly mentioned this, that if you don't treat iron deficiency anemia, it's kind of, it progresses over time. Like at first, if you have iron deficiency anemia, you might not feel that bad, but you just kind of consistently feel worse and worse. And over time you get weaker and weaker, and you can end up with, slow growth, problems with mental cognition, congestive heart failure. The good news is it's pretty easy to treat. Straightforward iron deficiency anemia, you just treat with ferrous sulfate. You've probably seen this in other classes, that vitamin C aids in absorption. So if they're drinking orange juice, if they're old enough to drink orange juice, that's a good idea if you're giving them iron supplements. Otherwise, it's best if it's on an empty stomach, because they have the most hydrochloric acid, and they'll get better absorption. So, we've talked about this when we were talking about infants, breastfeeding or iron fortified formula for the first 6 months, and then no milk until a year. And then this one here, so you can give vitamin C, but if they're not at the state that they're really drinking orange juice or anything, you give it between meals when there's a higher concentration of digestive acid for the best absorption if they need an iron supplement. So that is the most common type of anemia. Iron deficiency anemia affects all ethnic groups. It's, is mainly related to diet. And then sickle cell disease is another type of anemia. Does anyone know the ethnic population that is more likely to have sickle cell disease?
African American.
It's going to be African American. And so it's genetically inherited. So in order to have the disease, you have to get the gene from both parents. But if you inherit it from one, then you can have what's called sickle cell trait. And patients with sickle cell trait can have a wide variety of symptoms, where sometimes they have more problems than other patients, and some of them are asymptomatic. So I think most of you have heard about sickle cell before. So I would love if someone was willing to share how they would, summarize sickle cell anemia in a couple of sentences. Go ahead.
Inspired by the Nobel Prize winning discovery of nitric oxide for its important.
I know the
There,
cells are sickle shaped,
Doing more to support
and when
cells
they're
are
going through the arteries or whatever,
crystals.
it's like cut the arteries or whatever, and it causes like pain real bad.
All right, very, very good. So the cells are sickle shaped, so they're misshapen, so they're not the normal shape. And they clump, right? So they form blood clots more easily because they're not rounded. They stick together and they form clots more easily. And then they get stuck in small vessels, and then blood can't get through, and that causes a lot of pain. So very good. So what is something that is like a common sort of nursing intervention? If you have someone that comes in a sickle cell crisis and they're in a lot of pain, you're going to give pain medication, you're going to give oxygen, more than likely. What is something else that you're going to do to help relieve their pain?
Warm them up,
Warm them up.
pain meds,
Yep, very
what
good.
about fluids, like IV fluids?
Fluids.
oxygen.
Very good. Very good. You guys hit all of them. So it's really important, you always are going to be asked kind of priority questions. So this is a disease where one of your priorities is going to be placing an IV and getting them started on IV fluids, because their blood, it's almost like it's too thick because those cells are misshapen and they stick together. So you want to make sure that things are able to flow throughly. So they're going to need an IV and they're going to need IV fluid. And then the other things you mentioned, warming them up, oxygen, and good pain control. And this slide here is it kind of reiterates what we talked about earlier, that there are two types. There's the sickle cell disease and the sickle cell trait, where they only receive the gene from one parent. So when they receive the gene from both parents, their symptoms are more severe. So, and you guys knew that, the sickle cell crisis can be very painful. It can be fatal. They're also have problems with their spleen. They got a lot of sequestration of red blood cells in their spleen, so they're higher risk for infection than other patients. They're also at risk for stroke and complications of vaso-occlusive crisis because of those misshapen cells and the way that they stick together. So there's different types of crises. So the vaso-occlusive is going to be the most common. That's where the hemoglobin, the misshapen cells stick together in the small veins and blood can't get through, causes a painful crisis. Splenic sequestration, this is meaning that red blood cells are getting stuck in the spleen because the same thing, they clump together and they form clots. An aplastic crisis, this happens in sickle cell disease. It can happen with other disease processes. This is a crisis of the bone marrow where they're not able to produce cells. Then hyperhemolytic refers to massive destruction of red blood cells. And there's a couple of different reasons why this happens with sickle cell patients. Part of it is because they form all those clots because their cells are misshapen. And then as red blood cells go by there, it lyses them and it breaks them down. And there can also be an autoimmune component where their body attacks their own red blood cells. So you guys were right on in terms of the nursing interventions, starting the IV, getting them IV fluid, pain medication, oxygen. This is that hormone that we talked about earlier, the erythropoietin. It helps produce more blood cells. It triggers the bone marrow to produce more. They occasionally need a splenectomy, but it's not standard of care. It just depends on if there's a lot of disease to the spleen. Usually though, if there's sequestration, it kind of atrophies and stops working, but they don't necessarily have to take it out. But because of the problems with their spleen, they are at higher risk for infections. You want to make sure that you're preventing infection, preventing dehydration, preventing hypoxia. And then hemosiderosis refers to accumulation of iron in different tissues. So when you break down red blood cells and hemoglobin, you release iron, and that can build up in different tissues. And there's a specific medication, deferoxamine, which binds to the iron and helps remove it from the body. So that is the most common genetically inherited form of anemia. So we have like iron deficiency anemia, which is really related to diet. And now we're talking about different anemias that are genetically inherited. So there's sickle cell, and then there's thalassemia. So thalassemia is pretty similar to sickle cell in the sense that they produce red blood cells that are not normal. So they don't have the right or the same oxygen carrying capacity as patients that don't have thalassemia. And it's very similar to sickle cell in the sense that there's a thalassemia major and a thalassemia minor. So minor is going to be they inherit the gene from one parent, and then major is going to be they inherit the gene from both. And it's similar in the sense that if you get the gene from both parents, it's a more severe form of anemia, whereas if it's a minor, you might be asymptomatic or not even know that you have the disease. So if they have the thalassemia major, it's almost always diagnosed early in life. They don't feel well, they're pale, they're not feeding well. It's obvious that they're sick. It's really important to educate the family that this is a lifelong illness. There's no cure for thalassemia. And it's primarily treated with repeat blood transfusions. So they'll get multiple blood transfusions throughout their life to maintain a level of normally functioning red blood cells. And the Cooley's anemia is another name for the thalassemia major, which is meaning that they received the gene from both parents. It's the more severe form of the thalassemia. So they are at risk for early death just related to the profound anemia, and also their repeated blood transfusions causes them to have a lot of iron buildup in their body that can then cause damage to their other organs. And they can end up being a little bit misshapen because their bone marrow space enlarges to produce more red blood cells, and that ends up kind of affecting their facial features. So they can look kind of dysmorphic or off. And since it's genetically inherited, there's usually going to be, a family history of thalassemia. And so, genetic testing, et cetera, is important for diagnosing and supporting the family. So the overall goal is, maintaining an adequate hemoglobin level with blood transfusions and then preventing infection. So it has a lot of similarities to sickle cell disease. I'm going to go ahead and kind of leave this as a reference point, but you need to understand like the basic concepts. So I think that we've gone over the main points for thalassemia. On the other end of the spectrum, or a different sort of bleeding disorder or blood disorder, is going to be hemophilia. Does anyone heard of hemophilia, or can anyone tell the class what hemophilia is?
Just a free bleeder.
Right. So it's someone that they bleed a lot, right? So they're missing a specific clotting factor. So there's a bunch of different enzymes, proteins that are produced by the body that lead to clots being formed. So patients that have hemophilia, they're missing one of their clotting factors, so they are not able to form clots. It is also genetically inherited, but it's different. So it says here it's transmitted by symptom-free females. Does anyone understand that? Does anyone want to share what they think why that could be or how that would work?
Through your period.
Okay, so I could see why, since we're talking about blood and you're bleeding and your period. So this has to do with your chromosomes. So girls are XX and boys are XY. So transmitted by symptom-free females, the symptom-free female carries the genetic mutation on the X chromosome, and then she passes it on to her son, who is XY. So a boy receives an X chromosome from his mom and a Y chromosome from his dad. So boys, you only need one copy of the gene to have the disorder. So a woman will have, I'm sorry, if you're a woman, you would need two copies. So a woman would be symptom-free because she would have one X chromosome that had the disease and one that did not, and she would pass on that gene defect to her son, and he would automatically be symptomatic because he only receives one X chromosome. So it's kind of getting into the weeds of genetics, but the thing that I want you to remember is that it's going to be in males and it's passed on from the mom to the son,
Is
and
that
it's
something,
genetically inherited.
is that something that's usually tested on in depth, or is it just, we just need to know?
No, you could easily see a question about the fact that it would be in males. This
Okay.
is not, it's not going to be, it's genetically inherited and you're going to see it in males.
Okay. Just wanted to make sure.
Yeah, no, I understand it, because it kind of like, we don't, this isn't, it's peds and it's not genetics. So I don't want to like make you guys map out the chromosomes and see how things get transmitted.
Right.
But I would, so so I would, it is genetically inherited. So it does run in families, but they frequently don't know they have it. So it's going to be a woman that's a carrier and passes it on to her son.
Okay.
So, and it's, the treatment is going to be to replace the clotting factor that they're missing. So that's, once you figure out that they have hemophilia, then you have to figure out what type of hemophilia it is and then give them the clotting factor that they're missing.
Okay.
So, and there's a wide range. There's like mild hemophilia where it takes them a little bit longer to clot. And then there are patients that can bleed to death if they get cut. So to also kind of remember with hemophilia is they're not all the same. It is replacing a specific clotting factor that they're missing, and that there's a wide range of symptoms. So sometimes babies are going to be, there might be a family history. They might test right away. And then other kids, they'll be like 8, 9 years old before they're diagnosed. So, in the severe case, so like normally you and me, we don't have hemophilia. Our blood will clot in 3 to 6 minutes. But if you're a severe hemophiliac, it would take you an hour or longer to clot. So those are going to be your patients that are at risk for dying from hemophilia. So obviously there's going to be different nursing education. Like if you could die, if you bleed, it's probably not a good idea to play football. Whereas if it's just a mild hemophilia, you have to be a little bit more cautious, but you can still play contact sports. So just to think about like where they are on that spectrum of hemophilia, and then targeting your nursing care to what's appropriate to what their risks are. So we talked a lot about the fact that there's, a wide range of symptoms. So you need to make sure, sometimes like I said, sometimes kids, they're quite a bit older when they're diagnosed. So if you ever are working in an outpatient clinic, a pediatrician's office, and a mom is like, he just gets a lot of nosebleeds. I don't really know why. We have a humidifier. It's not that his nose is dry. And it takes a long time for the bleeding to stop. So, or if you give shots and you see that they get a bruise right away after you give them their immunization, and then this hemorrhage into a joint cavity, this is like a classic find. They'll have a lot of knee pain, and then you'll evaluate the knee and there's bleeding into that joint. These are all sort of symptoms of undiagnosed hemophilia. There's like I said, there are multiple clotting factors. So this DDAVP triggers the production of some clotting factors. So there are some patients that can be treated just with this DDAVP, which is a nasal spray. Most of the time, patients are treated with IV injections of the clotting factor that they're missing. So, almost always they're going to have like a primary hematologist and then a whole multidisciplinary team. And, one of the main things, you want kids to be kids and you want them to play and do the other things, but you need to be careful that you're advising parents on what's safe for their kid to do and giving them the best anticipatory guidance. So, talked about anemias, hemophilia, and now we're going to talk about platelets. So who can summarize, generally speaking, what platelets do in the body? Why do we need platelets?
It clots the
Is it
blood.
for blood
It
clotting?
helps the blood clot. So, hemophilia, people who have hemophilia, they can have more problems clotting, but the same thing, if you have a platelet disorder, if you don't have enough platelets, you're going to have a hard time clotting. So you're going to see, specific evidence of not clotting, of bleeding when someone has low platelets. So petechiae and purpura, these are both just discoloration of the skin. Petechiae are really, really small. Purpura is when they're greater than 4 millimeters. So they're pretty much the same thing, but there's a difference in size, where petechiae are pinpoint and then purpura are a little bit bigger. Ecchymosis is that discoloration of a bruise, and then hematoma is the actual swelling. So these are all the different things that you can see on the skin if a patient has a platelet disorder. So the most common platelet disorder that you're going to see in children is something called idiopathic thrombocytopenia purpura, which is it's abbreviated as ITP. And it's an autoimmune reaction. So usually kids have a viral illness, and then as they're getting over their viral illness, they start to have an autoimmune destruction of their platelets. So their body breaks down their platelets, and then they have this unexplained bleeding. So it usually is, bruising that you don't really know why. It can be, like I said, after a viral infection. And usually your platelet count when you have ITP is going to be around 20,000 when it's normal to be 150 to 400,000. The definitive diagnosis is going to be a bone marrow aspiration. So neurological assessments are a priority of care. Who can tell me why you think if you're having bleeding problems that you want to make sure you're doing a lot of neuro assessments?
Want to make sure the brain's
So
not
everything won't
bleeding.
bottom out.
Yeah, so you don't want to make sure they're not bleeding into their brain. So this is a common sort of priority question that I would expect you would see on your exam 3 and on your HESI. If you have a patient that has a propensity to bleed, one of your priority nursing interventions is going to be doing frequent neuro assessments. It's usually treated with prednisone and other medications that alter the immune system because it's an autoimmune reaction. And then it's usually self-limiting. So they usually get steroids for a few days and then it just goes away. They stop destroying their own platelets. It can become a chronic illness, but that doesn't happen very often. These are a list of drugs to avoid. I think that I would recognize them, but 2 of them on here are no longer on the market. So you're not going to be giving these medications because they're not available, but they're both NSAIDs that they decrease platelet aggregation. So they're going to work similar as aspirin, but they're no longer used. But they're in your textbook, so I'm going to keep them on the slide. But the ones that, in clinical practice, you need to pay most attention to is aspirin and then caffeine. Both of these medications decrease platelet aggregation so the platelets can't stick together. So if you already have a low platelet count, these would make the bleeding even worse. And I know it seems logical. You look at somebody and they have like a platelet count of 20,000 and they're bleeding, that you say, oh, we should give platelets. But you usually don't, because it's an autoimmune process where their body attacks the platelets. So if you give them a platelet transfusion, they'll break down those platelets also. So you usually treat the autoimmune process and then let them recover their platelet count on their own. So, obviously, you guys are very right on, you need platelets to clot. So your complications from ITP are all going to be related to bleeding from the GI tract, hemorrhosis, this is the bleeding into your joints, intracranial hemorrhage. And just as a side note, if kids are fully immunized, they're less likely to develop ITP because it usually follows a viral illness. Okay. Does anyone have any questions about that? Okay, I'm going to go ahead and give you a couple of discussion questions here that I want you guys to talk amongst yourself. Let's see here. I would love someone. Anisha, are you willing to be the recorder that tells the rest of the class what you talked about?
I guess so.
Thank you, Anisha. And if someone, you're going to have 2 discussions today. So if someone else you really want to talk to the rest of the class, you can let me know and you can do it for the next one. Let me pull up your questions for you. All right. So I'll put them in the chat. Let's see here. So there'll be a couple. Seriously.
Ah,
Okay. So the first one is review the effects of severe anemia on the heart. The next one is going to be think of food sources of iron for a child with iron deficiency anemia.
Are we needing to start this now?
It looks like she got kicked out or off the computer.
So did we just start talking about?
I guess so. I guess severe effects of anemia on the heart. I'm recording.
All the way down to the sidewalk.
And when people hear it,
What
they're not
happened?
sure what it is.
Yeah.
That's why you gotta tune in.
But it's a movement.
8 o'clock,
I will tune in.
CBS News.
Miss Pam, what you watching the news?
Can you hear it?
Yeah.
Okay. No, I'm not.
Okay, so what I said, uroblastosis fetalis. It's a disorder that can cause anemia and anemia that leads to heart failure in newborns, and it usually occurs with Rh negative mothers and Rh positive fathers.
What was the name of it?
I'm sorry, Makita, I missed the beginning.
Uroblastosis, erythroblastosis fetalis. I'm sorry, y'all. That's a condition that causes anemia, and that it can lead to heart failure. And it's diagnosed in utero.
Congestive heart failure is another one.
Well, with the red blood cells, the volume of it being low because of the anemia, that causes the oxygen not to be delivered. So that there in turn can cause the function of circulation not to work either. So then that would cause heart problems.
I'm just going to tell you right now, I may not be the best narrator for this part.
I'm cracking it.
It's fine, just do your best.
What did you say, Bobby Joe? I got the CHF, I got the erythroblastoanemia, and what was the one you said?
I was just saying with the anemia, it reduces the volume of your blood. And
It seems
so
like a little-
in
All right, so my
turn,
thought is
the
a
oxygen that's delivering it to the heart is not going to help it flow. So that there would then cause the function of your circulation to also decrease, which then would also lead to heart problems. Because you don't have enough blood flow, oxygenated blood flow to get to the heart.
It will cause CHF probably.
There's construction everywhere. So
It also leads to tachycardia and increased stroke volume.
And also cardiomegaly, because the heart will enlarge.
I don't need to.
Sorry, y'all are cutting in and out. Says my internet is unstable.
It's probably mine too, because it keeps flashing green.
Pedro, did
Okay.
you say something? Because I didn't hear you on that part.
I'm so sorry,
Oh,
you
I
guys.
said, it said tachycardia. It also can cause tachycardia and increased stroke volume.
Okay. Thank you.
And Pam said, Ms. Pam said cardiomegaly.
Meglia,
Yeah.
enlarged heart.
Shows us how scientists
So
are.
I got tachycardia and increased stroke volume. I got cardiomegaly. I said also we have reduces volume of the blood flow, CHF, and the erythroblastoanemia. Sound about right? I don't know if y'all heard me. It keeps going in and out.
All right, are you guys done? I hear like you guys are starting to quiet down.
I heard you, Nisha.
I was gonna say so far what we discussed for that was the erythroblastonemia. We have CHF. And then we have also reduces the blood volume in the heart. We have cardiomegaly, tachycardia, and increased stroke volume. And then I kind of didn't hear it because it kept cutting in and out. That's all I got, really.
So that sounds great. That was for the first one, the effects of anemia on the heart. Have you guys done the second one, the food sources for iron?
No, man, we didn't do that one yet.
All right. Well, so you guys were spot on. So very good. Go ahead and move on to the next one. I'll give you a couple more minutes. And then when I hear you quieting down, I'll jump back on.
Okay.
As she said in the thing, she was talking about the orange juice was a good source. And I would say green leafy vegetables.
And red meat.
Yeah,
Seafood.
and iron
Mhm.
supplements.
And beans.
Yeah.
What'd you say, Murata?
Did somebody say iron fortified formulas?
I said red meat and like liver too. Liver good for
Okay.
iron.
Yeah.
So I got red meat and liver. I got beans, iron supplements, seafood,
Green leafy
orange juice,
vegetables.
and green leafy vegetables.
Yes, like spinach, collards.
Yeah.
Fortified cereals.
Beets.
Iron fortified cereals. I think somebody said that like oatmeal and bran.
Yeah, so iron fortified cereals, breads, and pastas. What about dried fruits like raisins and apricots?
Yes. And then also too, with all that iron being taken, your bowels and stuff, you have to drink plenty of fluids to keep, everything moving, because iron will constipate you.
And fiber will help with the constipation.
Dark chocolate is high in iron too.
Yes. And also with your teeth, it will stain. So if it's liquid iron, a straw, will help your teeth from staining.
Okay, so I got teeth stain. So you want to make sure you use a straw. You want to increase your fluids due to constipation, and you also want to increase your fiber. I got iron in fortified cereals. I got apricots. I got beets, green leafy vegetables, red meats and liver, beans, iron supplements, seafood, and orange juice.
And also with children, oatmeal is a good source of iron and fiber.
Take it with vitamin C for better absorption, like orange juice. Well, you said orange juice already.
Yes.
I put orange juice and vitamin C.
All right, I heard you
Just take
guys.
the
That's
tablet.
you guys did a good job. So the green leafy vegetables, things like spinach, you got the red meat, the liver, etc. And then it sometimes is a little bit tricky. This is something that I've seen before. So egg yolk is high in iron, but egg whites are not. So sometimes they differentiate between those on tests. And then the fortified cereals, bran and wheat germ are also good sources. A lot of the cereal and stuff like that is fortified with iron, but kind of even without being fortified, both bran and wheat germ are good sources of iron. So good job. So your last one to talk about as a group is the pathology, like what makes sickle cell anemia be sickle cell anemia, and what you expect to see in a patient that has sickle cell anemia.
Well, you're definitely gonna see that they are very fatigued, very tired, and in pain, in constant pain.
Lack of oxygen to the cell causes it to be sickle shaped, and it causes the pain in the vessel.
Also, their life expectancy is cut down to, I think, like
Yes.
45 years old.
As she stated, is more known in the African American society. It's a trait if one parent has it, and it's a disease if both parents have it. And it's more critical if both parents have it.
Symptoms can still be present in the trait too as well. Not as
Yes.
public as it would be with the actual disease, but still present.
Avoid cold temperatures. There's a drug for it. It starts with the E. I don't know how to pronounce it. Erythropoietin or something is the drug used for that. I think that's how to pronounce it. I'm not for sure.
Is it erythropoietin?
That's it. I had a friend that passed away from that disease, sickle cell.
It breaks the body down very, very quickly.
Yes, real
Not.
fragile,
Mhm.
dry skin, real dry skin.
All right, so I feel like you guys are rounded up. Does somebody want to give a summary? It doesn't have to be Anisha. If someone else wants to give a summary, that's fine.
I mean, I wrote it. I got fatigue, pain, low O2, decreased life expectancy. You want to avoid cold temps. The drug that's given is the erythropoietin. It breaks down the body quickly. You have dry skin. I do also notice sometimes when I see sickle cell, like you can tell the discoloration, almost like jaundice in their eyes. The yellowish tinge.
And that's going to be because of all that breakdown. They release bilirubin when they break down their cells, which gives them that kind of that orange color. And then you guys told me in class, but I do know, for future tests that you need to remember one of your nursing priorities is going to be to get an IV and to get them on IV fluid. And that's so that their blood isn't so sticky, because those misshapen cells, they form clots more easily. So you want to make sure they're on IV fluid to keep their blood flowing, especially when they're in a sickle cell crisis. All right, you guys did great today. We're going to do a really, really brief Kahoot just to kind of bring it all home. So I'm going to put it up over here. So what food is rich in iron? Banana, carrot, cream of wheat, or egg whites? Very good. Yeah. So the egg yolks are high in iron, but not the egg whites. So cream of wheat is the best answer there. Which statement by a mother may indicate a cause for her 9-month-old's iron deficiency anemia? I gave her crackers to chew on. Formula is expensive, so we use cow's milk. She eats a lot of fruit, or she almost never drinks water. Right. So this is the, a common cause of iron deficiency anemia in infants, because we don't start cow's milk till at least a year. They don't really digest it, can cause some bleeding, and also can block the absorption of iron. So good job. What should the nurse closely assess in a child recovering from a transfusion? Lethargy, fever, jaundice, or bradycardia? So, right. So when you're giving a blood transfusion, you're worried about a transfusion reaction, which is almost always going to be a fever. You would expect tachycardia, maybe itching and hives, lower back pain. So the best answer based on these is going to be the fever. So the child receiving a transfusion complains of back pain and itching. What is the best initial action by the nurse? Disconnect the IV blood and run normal saline through the IV, notify the charge nurse, or give Benadryl. Okay, so a couple of you got this. This one is a little bit trickier. So if you're having back pain and itching, you're worried that they're having a transfusion reaction. So you definitely want to stop the blood. And the reason why the yellow is better than the red is because you want to make sure that IV stays patent. So you don't want to just disconnect the IV. You want to run something through it to make sure that if you need to give IV medications, you have a good solid line that's going to work. So the nurse notes that a 4-year-old child has bruising and petechiae on his extremities. Which lab value does the nurse suspect? A leukocyte count of 14,000, a hemoglobin of 8, hematocrit of 36, or a platelet count of 25,000. Right, very good. So you're worried about a platelet count being low and that's causing the bleeding. So a child is diagnosed with iron deficiency anemia. What will the nurse explain can occur if the disorder goes untreated? Heart failure, pulmonary embolism, infection, or hemorrhage? All right, very good. Yeah. So if they have untreated iron deficiency anemia over time, it can lead to heart failure. So a child with leukemia has widespread purpura and a platelet count of 19,000. What is the priority nursing intervention? To place an IV, to assess the child's neurologic status, monitor vital signs during a platelet transfusion, or educate the family on preventing bleeding? All right, so this one is kind of, in reality, you're probably going to be doing all of these things, but the priority is going to be making sure that they're not having any sort of bleeding to their brain. So this is going to be the assess the neurological status is going to be your highest priority. So what would the nurse include in a teaching plan about mouth care for a child receiving chemotherapy? Use a soft toothbrush, avoid using a water pick, inspect mouth weekly for ulcers, or use a commercial mouthwash. Right. So when they're undergoing chemotherapy, they're at a lot of risk for breakdown ulcers in their mouth. So you want to make sure they're using a soft toothbrush. They can use a water pick. They don't use a commercial mouthwash. If anything, they have something that kind of calms their gums that they have a prescription for. And you're going to look for ulcers a lot more often than weekly. So an adolescent with Hodgkin's disease is crying and states, "I'm so scared." What's the best response by the nurse? "You shouldn't feel that way. I understand how you must feel. Tell me why you're so scared, or you should go talk to your parents, not me." All right, very good. So you want to have open communication, encourage her to express her feelings. Awesome. All right, last one. So the nurse is caring for a child with a low platelet count. What skin assessment would alert the nurse to bleeding? Ecchymosis, hematoma, petechiae, or all of the above? Good job. All of the above. Very nice. All right. Very good job, you guys. So when I post the lecture, I'll post the links to the Kahoots if you want to practice. So does anyone have any questions? If not, we'll go ahead and move on to the next PowerPoint. Right.
Can we take a brief break?
You may. Do you guys want to take a 5 or a 10-minute break?
Just 5.
5? Okay. I'll see you back here at 10 o'clock. Okay, so it looks like most of you are back and I see most of the cameras on. So just to keep us on schedule, make sure you guys get out of here on time. I'm going to go ahead and start the next PowerPoint. So the next thing that we're going to talk about are gastrointestinal conditions in children. And it's just going to start off with like a general overview, just to remember that the GI tract, it's from your mouth all the way to your anus. So there's a pretty big section of your body that makes up your GI tract. And the primary purpose of your GI tract is to break down what you eat into absorbable nutrients that you can then use by your body. So when we talk about systemic signs, we're talking about signs that you see throughout your body. So a most common or a common sort of systemic sign that you might see is failure to thrive or not gaining weight appropriately. And then also there's some degree of itching. You can have itching when you have liver dysfunction, or you can have itching when you're having a food allergy and you might have some general inflammation in your GI tract. So sometimes like a more subtle sign of a problem with your GI tract is just widespread itching. And then you also have your local signs like vomiting, diarrhea, pain, constipation, rectal bleeding. Hemoptysis is bleeding or vomiting blood. So, you know, we talked in the beginning of the class that growth and development is hugely important for kids. So you're going to, you know, really put an emphasis on making sure they're getting good nutrition and that they're growing appropriately. If they're not getting enough nutrition, or if they're not able to absorb nutrients, or something is going wrong with their GI tract, that can lead to developmental delays. They can also have skin problems kind of related to that itching, and then pain and discomfort if they have a chronic GI problem that will also need to be addressed. So there's a couple couple sort of buckets that you can put gastrointestinal problems in. One is going to be congenital and the other is going to be like infectious. So congenital just refers to you're born with it, right? So congenital gastrointestinal problem is a gastrointestinal problem that you're born with. It can be genetic, it cannot be genetic, but the main thing is it means that you're born with it. So something esophageal atresia, and or transesophageal fistula. So atresia means sort of a bad connection. So if you have esophageal atresia, your esophagus isn't hooked up normally. Transesophageal fistula means there's communication between the esophagus and the trachea. So when kids eat, some of their food falls into their lungs because there's a connection between the trachea and the esophagus. So when you're born with a transesophageal fistula, a common presenting symptom is that you cough a lot when you eat, because you're in essence, that milk that you're eating is falling down into your lungs. There are 4 different types. You don't need to memorize the 4 different types, but you need to know a common presenting symptom is coughing when you're eating, and that there are different types of transesophageal fistulas. Another congenital or problem with your GI tract is what's called the imperforate anus. So when this happens, you know, there's either a narrowing or complete lack of an anus. So you either have a hard time getting your stool out of your colon, or it can't pass at all. So you don't have a normal opening for your poop to leave your body. And this is something that kids are born with. So there's something called meconium. So does anyone know what meconium is? Has anyone heard of meconium?
That's that
First
first
poop.
fecal movement for the baby.
Yeah. So this is going to be like even before they've eaten anything. So they're going to be, you know, their GI tract is starting to they swallow a small amount of amniotic fluid. They have some stuff moving through their GI tract before they're born. So this meconium is going to be that first poop that is, you know, even if they haven't had anything to eat, they should still pass a meconium stool. So if they don't pass meconium in the first 24 hours, that's an emergency that you need to follow up and find out why. And one of the reasons could be that they have an imperforate anus and they're not able to get the stool out of their body. So you should always, I would make a list of things that could be associated with not passing meconium, because that's a common way to sort of test your knowledge of congenital defects. So this is one of the congenital defects where it is possible that the baby won't pass the stool, and it's because there's something wrong with their anus. So if you notice that it needs to be reported, no baby should ever go home from the hospital before they pooped. So once you determine there's something wrong, you need to make them MPO, they're going to need to have surgery. Sometimes they actually do a colostomy. Does anyone know what a colostomy is?
Yeah, it's like a bag for like
Redirecting
your
it.
poop.
All right, both of you are right. So you pull the colon up to your skin on your stomach. So instead of the poop draining out the anus, it drains through a fistula in your skin, and you put a bag over the fistula. So this is a way to redirect their colon so that it doesn't have to come out their anus. Sometimes they can repair the anus and it'll continue to come out where it normally does, or they might have to pull the colon up to the skin. And then something else associated problems with the GI tract is pyloric stenosis, which is, you need to remember pyloric stenosis is particularly associated with projectile vomiting. So the pylorus is the connection between the stomach and the small intestine. So if it's stenosis, it's narrowed. So babies with pyloric stenosis, they have a hard time draining their stomach. What they eat doesn't go down into their small intestine, so then they vomit it up. So it's associated with projectile emesis. It's not like normal baby spit up at all. It's this very kind of violent projectile emesis. And they can get easily dehydrated, obviously, because they're vomiting, and they're usually, otherwise they don't act sick. You know, they don't have a fever, they're vigorously hungry, they want to eat. And sometimes you can feel an olive-shaped mass in the right upper quadrant of their abdomen. So do you think these kids need surgery?
Yes, to open it up.
Yep, they're going to need surgery. So you're going to make them MPO and they're going to have surgery. Very good. Another sort of GI problem with kids is celiac disease. Has anyone heard of celiac disease?
I have.
Yes.
Yeah.
Yes.
What's the main thing you have to avoid if you're a celiac that you can't
Isn't
eat?
it
Gluten. Isn't it?
gluten? Yeah.
So it's a gluten intolerance. So it causes inflammation of the GI tract. They're not able to break down and digest gluten. So all of these things here, wheat, barley, oats, and rye, they contain gluten. So patients who have celiac disease, they can't eat these. What is something you think they could eat that you could that would maybe substitute these things?
Fruits and vegetables.
They can eat fruits and vegetables, they can eat meat, they can eat rice. So a lot of times people that have celiac disease will eat more rice than other people because it's kind of sticky. You can put it with fruits and vegetables, meats. So if you have this, gluten intolerance, repeated exposure causes damage and malabsorption, and that usually they have some abdominal distension and generally not feeling well. So there's different sort of categories of celiac disease. So the most common is going to be the classic, where they have diarrhea, abdominal pain, and then damage to their small intestine. And atypical is they really have mild symptoms, but they still have the gluten intolerance. And then the silent is they don't really have symptoms, but then if you do an endoscopy and look at their small intestine, it looks inflamed and damaged. So the most common is going to be the classic, but you should recognize that it doesn't always present the same in all patients. So you would expect with celiac disease, they're not going to grow normally. They're going to have failure to thrive, irritable, bulky, frothy stools. It's definitively diagnosed with a small bowel biopsy, and then they can also look at your immunoglobulin A. So there's no treatment. They just have to avoid gluten for their entire life. So these are the things that they can eat: wheat, barley, oats, and rye. And they're going to need a lot of work with a nutritionist because it's really hard to avoid gluten in your diet. So this is another one that if you were to make a list of things that could present with failure to pass meconium, Hirschsprung's is on that list. The first one was the imperforate anus, and then also Hirschsprung's. These are both associated with not passing a meconium school within the first 24 to 48 hours. So this is more of a nerve problem. They don't have normal nerve sensation to their bowel, so they don't have what's called peristalsis. Their bowel doesn't squeeze and relax, and it's not able to move things down. So if they do pass stools, they're kind of thin and ribbon-like, and It can cause abdominal distension. It can cause like an obstruction. It can be acute or chronic. Hirschsprung's is also associated with Down syndrome. So babies that have Down syndrome are more likely to have Hirschsprung's. So here's this, I mentioned to you guys, you should be on the lookout for Hirschsprung's if they have failure to pass a meconium stool. Since it can be acute or chronic and there's a wide variety of symptoms, sometimes it's diagnosed in older kids. Sometimes they'll pass this stool and there'll just be like a child that gets constipated a lot and they treat it frequently and then they're ultimately diagnosed with Hirschsprung's. So they should ultimately have it treated. If not, they're going to be at risk for chronic constipation, obstruction. And then something else that you can be born with, this is not going to be associated with not passing school. It's called a Meckel's diverticulum. So that's like a pouch that forms usually near the ileocecal valve. So it's like an outpoaching of the small intestine and it can cause rectal bleeding. That little sac that's there is, it's not normal to have it pouch out and it's subject to bleeding. And you're going to see it more often in boys than in girls. And it does require surgery, sorry. And then hernia. Hernias are more common in adults than they are in kids. Has anyone had a hernia or have any experience with hernias?
Yeah, I had one as a kid.
You had one when you were a kid, okay. Did you, and you had surgery?
Yeah.
Yep, okay. Who can give like a general definition of what a hernia is?
Is it like the vessel sticking out? The umbilical? Yeah.
So you can have an umbilical hernia. So generally there's, it's when abdominal contents, either part of the intestines or the fat that surrounds the intestines, push out through the muscle wall. So you'll see like a bulging coming out. In kids, you'll see it in two places, inguinal, which is going to be in their groin, and then the umbilical, so right where their belly button is. So you'll see an outpoaching, and it's actually the intestine or the fat that surrounds the intestine that pouches out through the abdominal wall. So babies can be born with hernias or they can develop them over time. So it can either be congenital or acquired. Excuse me. It's considered reducible if you can push it back in easily. And if it's not reducible, then you need to be worried about being incarcerated. So strangulated, incarcerated, they're not getting blood flow to that section that's pouching out, and that requires surgery. So if it's soft, you can push it back in and doesn't bother them. They don't necessarily need to have surgery. But if you're not able to easily push it back in or it's really painful, that's an indication they're not getting blood flow to that tissue that's pouching out and they need to have surgery to repair it. So then, children that have surgery, that need surgery, you expect them to be in pain, to have vomiting. And once it's diagnosed, they usually go that day. And generally speaking, they're able to reduce it, they're able to get it back down, and they tend to live a normal life from that point forward. So those are all of the things that you can be born with that have to do with your GI tract. And now we're going to talk about ingestion, poisoning, worms, vomiting, diarrhea, things like that. These are things that are going to be acquired problems with your GI tract after you're born. So, colitis just means an inflammation of the colon. It can be related to an infection. And then enterocolitis is inflammation of the colon and the small intestine. So just to kind of be aware that you can have inflammation and problems with your GI tract throughout your GI tract. And one of the things that you'll see when you're having colitis or enterocolitis is diarrhea. And this could be food intolerance, like your body isn't able to break down something that you ate. It could be related to overfeeding, improper formula preparation, or ingestion of high amounts of sorbitol. Sorbitol is a type of sweetener. So some foods are sweetened with sorbitol, and sorbitol can cause diarrhea. When you have a patient that has diarrhea, the main thing you're worried about is dehydration, so fluid loss, and then electrolyte imbalances. So if you have somebody that has a gastroenteritis, vomiting, diarrhea, the main thing that you want to do is get rid of what's causing the vomiting and diarrhea. As a nurse, you need to be paying close attention to their fluid balance and their electrolytes, doing a really good job of monitoring their eyes and nose. And then teaching about hand hygiene to stop the spread of infection. Vomiting also goes with problems with your GI tract. It's usually related, or it can often be related, to improper feeding techniques. So what sorts of things do you think could lead to vomiting in a baby that have to do with feeding techniques?
Could be you're overfeeding them, or they're not.
Overfeeding, very good. Or not what?
Like I would say, or it's like they're not getting. It's like they're trying to drink the milk, but it's like not going down, so it's causing them to spit up.
Or it could be the
Or feeding them the wrong
wrong
kind of food.
formula.
Yeah, but
Yeah.
it could be the wrong formula, acidic level.
Not burping them.
Yep, and not burping them enough. Very good. We talked a little bit when we did the neuro chapter, we talked about Cushing's triad, increased intracranial pressure. So sometimes if they're vomiting a lot, they could actually have increased intracranial pressure. And they could also have an infection that's causing vomiting. If they're vomiting, they're at risk for aspiration pneumonia. So they're vomiting, and then some of that vomit can then fall back into their lungs. So you guys got all of this. Burp them. If they're vomiting, you want to put them on their side so they're less likely to aspirate. They may need IV fluids. And then if you're reintroducing foods, you want to give their stomach some time. So start some IV fluid, make sure they stop vomiting before you really start giving them food. So you're always going to be documenting, in nursing, documentation is so important for both vomiting and diarrhea. What time they vomited or had diarrhea, what did it look like, how much, if you gave them any medications. So diarrhea, we all know what diarrhea is. It's considered chronic if it lasts for more than 2 weeks. One thing that's kind of important when you're working in pediatrics, kids get diarrhea all the time. And a lot of times it freaks parents out. So just remember that it can take 5 to 7 days for diarrhea to really go away. If they're not dehydrated, it's okay. You can kind of wait it out at home. If it lasts more than 2 weeks, you need to do a more of an investigation as to what's going on. So, watery, miscolored stool can be smelly. If they're losing weight, if they have a high fever, they're really listless, these are all symptoms that it could be infectious. They really potentially are getting dehydrated and need to come into the emergency room. And this is a point here. In severe cases, excessive loss of bicarbonate from the GI tract results in acidosis. So when you have either vomiting or diarrhea, they both cause acid-base imbalances, but it's common in nursing world, HESI and NCLEX, to get you to differentiate which one causes acidosis and which one causes an alkalosis. So diarrhea is acidosis. So if you are ever presented with a question and they ask you what type of acid-base imbalance you think your patient's going to have if they have diarrhea, the correct answer is acidosis. And then what do you think for vomiting? Does vomiting cause acidosis or alkalosis?
Is it alkalosis?
Alkalosis. So when you vomit, when you vomit, you lose acid because you vomit hydrochloric acid. So if you lose too much acid, you end up with an alkalosis. And which one, like when you look at a pH, what's a normal pH? If there's no acid-base imbalance, what's normal?
7.35.
7.35 to 7.45. And when you have an acidosis, does your pH go up or down?
Down.
It goes down. So a pH, if they have a pH at less than 7.35, then that's acidotic. And if it's higher than 7.45, then that's alkalosis. So I would remember those key sort of numbers, being able to recognize what's acid and what's base. And if you see a blood gas, you would be like, oh, it's 7.5, that's alkalosis. And alkalosis is going to be associated with vomiting, not diarrhea. And then acidosis is your diarrhea. So kind of on the other end of the spectrum, there's constipation. And it can be a symptom of something else, or it could be related to their diet. Maybe they're not getting enough water. Maybe they're afraid to poop. They don't spend enough time on the toilet. You generally speaking don't use laxatives or enemas in kids. You try to do diet modification and behavior before you really start going down the medication pathway. So the definition of constipation is fewer than several bowel movements in a 2-week period. And when you're evaluating, you want to make sure you know how much they're eating and what they're eating and how much water they're drinking. and how active they are, have like a note of what the stool looks like. You're usually going to start increasing fiber, increasing fluids before you start any medications. If you started a medications, it would be something really mild like a stool softener. An example would be Colace. So there's a couple reasons. Kids are at higher risk for dehydration than adults. I want you guys to think, based on what we've talked about this term, what are some reasons that kids might get dehydrated more easily than adults?
Immaturity of their organs.
Yeah, so immature kidneys, they're not able to concentrate their urine, so they end up losing more fluid through their urine. Very good. What's another reason?
They just don't drink as much fluids or as what, as we do.
Yeah, I mean, they might not, right? Because they're dependent on you for the most part. So they might not just know to get water and drink as much fluid. And what's different about their body?
And then too, with their skin and their temperature of the skin, the brown skin or whatever they.
Okay, so they have a higher body surface area to their overall size. So they lose more fluid through their skin. And they also have a higher metabolic rate. So they need more calories based on their size. So they tend to run a little bit hotter. They have a higher body temperature. They lose more fluid through their skin. And because of they have a higher body surface area to weight and because of their kidneys. So those are all different reasons why they're more likely to become dehydrated. So since they can develop dehydration more easily, it can happen more quickly. So they can kind of look like they're okay, and then they just kind of get sick really quickly. So you need to be on the lookout since they're at risk for dehydration and kind of staying on top of it, referring parents to the emergency room before they're really listless. They might need IV fluid, etc. So you worry about fluid and you worry about electrolytes. Generally speaking, you don't really have symptoms of dehydration until you've lost about 4% of your fluid, and then it's considered severe dehydration if you've lost more than 10%. A lot of times you can start with oral fluids. If they're vomiting, you generally don't start with oral fluids. If they're vomiting everything up, you're more likely to just refer them to the emergency department to get started on IV fluids. If they have diarrhea and they're not vomiting, you might try oral fluids at home before you have them come in. And then parenteral fluids, this just means IV fluids. So dehydration is you've lost too much fluid. We talked about 4% when you're symptomatic, 10% it's more severe. Just like IV fluid, there's different types of dehydration. So isotonic, hypotonic, and hypertonic. So isotonic is you've lost fluid. You lost both fluid and your solutes. Hypotonic is you've lost more like salt and you've lost some water, and hypertonic is you've lost more water than salt. So you're going to adjust your IV fluid based on what type of dehydration. Honestly, isotonic is the most common. And you would treat isotonic dehydration with an isotonic fluid like normal saline. But you do need to recognize that you can have different electrolyte problems with dehydration, and you need to give an appropriate IV fluid. So if for some reason, for example, children have a hypotonic dehydration, you wouldn't want them drinking water because that would make their hypotonic dehydration worse. And if they had hypertonic, you wouldn't want them, eating something that's really salty because that would make their hypertonic dehydration worse. So, if you're ever given a clue in a question that there's a specific type of dehydration, you want to make sure that you're choosing a fluid replacement that is appropriate for that type of dehydration. And generally speaking, we don't replace potassium, even if it's a little bit low when kids are dehydrated until they have normal urinary output. Why do you guys think that's true? Why do you wait to replace potassium?
Because too much is deadly.
Too much is deadly. Very good. So if you overshoot and their kidneys aren't working, you could put them into cardiac arrhythmia. So you wait till their kidneys are working normally and they're peeing before you start replacing their potassium, because you don't want to make them hyperkalemic.
I have a question. I'm sorry.
Yeah.
Can you go back? Can you repeat what you said about the water you would give, who you wouldn't give water to? And
yeah. So if they have a hypotonic dehydration, you would not give them water.
Oh, the hypotonic, you would not.
Right.
Okay.
Right. But if they had a hypertonic dehydration, you would not give them chicken soup or something that's really salty.
Okay.
Because the hypotonic, hypotonic means that there's like more water than other particles in the blood.
Right.
And then hypertonic is opposite. So if you're hypotonic, water would just make the hypotonicity
would
worse.
make it worse. Right. Okay. All right. Thank you.
Sure. So on the other end of the spectrum, you can have overhydration. A common thing that you might think of would be someone that actually drinks too much water and they're like fluid overloaded with water. So if they're fluid overloaded with water, do you think they would be hypotonic or hypertonic?
Hypo.
Hypo. Yeah, very good. So things that you would see in overhydration would be edema, would be the main thing.
Would you really see that though a lot in kids? I mean, is that something that's not really something that would be common in kids, would it?
No, like I said, almost always in kids, it's going to be an isotonic dehydration where they've simply lost fluid.
Okay.
It's not usually hypo or hyper. I've seen a couple kids that were they weren't neurologically normal and they were left with access to a hose and they just drink water from the hose all day, but it does not happen very often. You're absolutely right. It's hypotonic dehydration in a kid is rare.
Okay.
Okay. So if they develop overhydration, sometimes though you can end up with overhydration if they're in the hospital and they get too much IV fluid. So making sure that you know like what an appropriate amount of IV fluid is for your patient and make sure they're not getting too much fluid. And this is going to go back to the question that you asked. So if it's hypertonic, you're not going to do something like tomato juice or Campbell's soup. And if it's hypotonic, you're not going to give them water. So I would recognize, both the hypertonic and the hypotonic and sort of engaging your nursing interventions based on the type of dehydration that they have or overhydration.
Okay.
Does that make sense?
Yeah. I was getting it backwards. That's why I wanted you to repeat it, because in my head I was thinking the opposite, but it still didn't sound right. That's just why I wanted you to repeat it to make sure.
Okay, sure, of course.
Thank you.
Yeah. So, overhydration, regardless of the cause, you want to be monitoring them, monitoring their edema, monitoring their vital signs, their weights, their urine output, and then honestly, and looking closely at their electrolytes. Particularly, you're going to be most worried about sodium, but keeping a track on all of those things. So those are, related to infections or either too much or not enough fluid, etc. Something that you probably deal with as a nurse if you're working in pediatrics is failure to thrive. So failure to thrive just generally means like not gaining weight appropriately. And there's two general causes. Physiologic, like they have celiac disease or something where they're not able to absorb their nutrients, or there's non-organic, which is probably related to parenting, like the parents aren't giving them enough to eat, or they're mixing the formula incorrectly, or there's something in their environment neglect that's causing them to not gain weight normally. So I'm just going to throw this out there. How would you think as a nurse you would respond to the parent if you learned that the mom wasn't feeding the baby enough at home and the baby came in for being too thin? Like how would you feel as a nurse, and how would you respond to that family?
I think the first thing you would need to do is, obviously you have to take your own personal feelings out of it because you don't know where they're coming from. So the first thing I think you would need to maybe just assess and ask questions on why, maybe there's a legit reason outside of just neglect.
Okay, very good. So kind of leaving your own personal feelings at the door, trying to be non-judgmental, and still like until somebody like social services or something terminates the parental contact or parental rights, you want that mom or that dad, whoever's with the baby, involved as much as possible, feeding them, involved in their care. So you can't make any decisions just on your own, and you can't let how like that initial reaction of like, how could you do that to your baby, really affect how you care for the baby. And baby kid, I mean, they're part of a family unit, so that entire family unit is your responsibility.
Also, I would think about like asking like probing questions, because sometimes the mom might not know that they're supposed to be feeding the baby a certain amount of ounces of milk or correctly formula too. So you could try to dig into it a little bit more, ask her to fix a bottle in front of you just to see it, to evaluate if she needs to go up on the formula or add cereal to the bottle too.
Yeah, very good. So that's
Educating.
educating. Yeah, and being non-judgmental, because it's not, if they're seen in the clinic and they're not gaining weight, it's not unusual that they'll get admitted into the hospital. So all of those things that you're saying are really good. Talking to the parents, that example of like having her show you how to make the formula. Maybe she doesn't know how many scoops she's supposed to put in for a bottle if she's using a powder mixed with water, etc. So all of those things are really, really good, trying to get really to the bottom of what's going on. So all of the things that you said were really good. Remember that it can be neglect, so you're going to have to kind of have that out there as your possibility of what's going on. But that doesn't mean that the mom's, destined to lose custody of her kid or anything like that. Maybe it's an education. Maybe there's something that you can address. There's some financial stress that she's not able to buy the formula that you can address. So you have to really get into what's going on and help the mom problem solve. Sometimes, parents that aren't really bonded, moms that aren't really bonded with their pregnancy, then you'll see them neglect their kid after they're born. So just to kind of be aware that this can all start happening even before the kid's born. And you should really, if you're working with this family or this mom, that you should be documenting all of your observations very closely, so you can really see as healthcare providers the trajectory of what happened, so you can give them the best support. So they're almost like most things that are complicated in kids is going to be a multidisciplinary team. Sometimes Child Protective Services gets involved and takes the kid away from the parents. And assigning the same nursing staff is really, really important, because usually the parents will bond with a couple of nurses and they'll be more receptive to education and teaching from those nurses that they know. So trying to get like a team of primary nurses for the kid that's been admitted for Failure to Thrive. And you guys have said a lot of this is that, supporting the mom, you don't want to be judgmental at all. You don't know what the diagnosis is when they come in. It could be something related to their GI tract, and it has nothing to do with how the mom's feeding the baby. But that also, if it is neglect, we've talked a lot about theorists, trust versus mistrust as an infant, and your personality develops. So if it's a problem with parent bonding and neglect, that is something that you really need to address, because it'll affect the kid long-term if that's happening at home.
I have a question. In regards to Failure to Thrive, the scales are based on formula fed babies, correct?
Well, you mean in terms of, it's just going to give their weight. Are you talking about like the growth charts, like how much they should weigh based?
Yes.
So, but the cutoff is below the 3rd percentile. So even a breastfed baby that might not weigh as much as a formula fed baby, if you're below the 3rd percentile, you're really low on your weight.
Okay, because my daughter was diagnosed with Failure to Thrive. However, I breastfed my daughter all the way up until she was 10 months.
Okay.
She was in the 15th percentile as far as weight, but as far as her height, she was always in the 80th percentile. So I figured like her height was more so accumulating for like her overall growth versus her weight.
Yeah. And also, are you are you kind of tall and thin? Like a lot of times kids kind of have the same.
And I was as well.
Yeah. So usually, it sounds like maybe they were jumping the gun on that diagnosis. Like I wasn't involved, so I don't know, but generally speaking, it's a weight below the 3rd percentile. So 15th, and if she was following the curve, like if she was born like 15th percentile and count along, and her height and her weight followed the same curve without dropping, then that wouldn't really be concerning for Failure to Thrive. You worry if it's below the 3rd, or if you see a drop on their curve, like if they're at the 20th and they drop to the 10th percentile.
I figured that. Thank you.
Yeah. So that's the review of failure to thrive. And for those of you that have had med-surg, I think all of you have. So kids can also get appendicitis. So appendicitis happens in kids and adults. If you've ever been an adult around an adult that had appendicitis, the care for kids is pretty similar. It requires abdominal surgery. Excuse me, it requires abdominal surgery. So they usually come in with pain, vomiting. You do need to remember that it's really traditionally localized in the right lower quadrant. And if it's ruptured, it's a more severe condition than if it's not ruptured. So if it ruptures, it can lead to peritonitis or septicemia, where they get bacteria into their bloodstream. So I would remember this McBurney's point. That's specifically the right lower quadrant that's associated with appendicitis. Guarding is they don't really want you to touch them. And then rebound tenderness. Who knows what rebound tenderness is?
When you press and
Around
release.
Yeah, so you press down and it's not that painful, but then as you're lifting your hand up, that's when the pain is more severe. So it's when it rebounds after you press down that they really have the worst pain. And something also associated with appendicitis is that when you lift the thigh, when they're in the supine, when they're lying supine, that can cause pain. So, I would remember for sure McBurney's point, right lower quadrant, rebound tenderness. These are all sort of classic symptoms of appendicitis. So it's usually definitively diagnosed with either a CT scan or an ultrasound. They also tend to do blood tests looking at, infection. You surgically remove the appendix, and it's going to be, if you've ever taken care of a patient that's had surgery, it's going to be a lot of the same sort of nursing care. So what sorts of things do you do commonly after someone that's had abdominal surgery as a nurse?
Bounding.
Could you say that again?
Binding, like you wrap them.
Okay.
Binding, something to hold
Yep.
them.
Do you want bowel sounds?
Bowel
Other
sounds.
bowel sounds. Do you do something like pain? Very good. How about the squeezers on their legs if they're not walking?
Compression devices to prevent clotting.
Yeah. And how about atelectasis? What do you do for atelectasis to prevent atelectasis?
Incentive spirometry.
Yeah, something for kids. Sometimes kids blow bubbles or they have other toys that they blow with, but you want to make sure that they're using their lungs. Okay, so in the world of pediatrics, we have to talk about worms. We don't really talk about worms much in adults. There's two main types of worms. There's pinworms and then there's roundworms. So pinworms are itty bitty. They look like little grains of rice. And they're very, very itchy. So in order to get infected with pinworms, you actually have to get the eggs in your mouth. So kids will like scratch their butt or scratch, somebody else's butt, and then they'll put their fingers in their mouth. And that's how they get their worm infection. I know, it's gross. So there's something called the Scotch tape test, which is literally just putting Scotch tape around near their anus. And then when you pull the tape off, you'll see the little worms on there. So it's really, really contagious. It can spread through families or through daycares. And kids, a lot of kids just kind of suck on their thumbs or their fingers. So that's how it spreads from kid to kid. So one of the main sort of nursing interventions is cleaning everything in hot water and making sure the kids' nails are really short. Because if there's anything under the nail, when they put their fingers in their mouth, they can then eat the eggs. And the eggs have to get ingested into their GI tract for them to have the infection. So pinworms, they're annoying. They're really itchy. They can be hard to get rid of because kids pass them amongst each other really easily. But they don't tend to make kids really sick. More than anything, they just are really annoying and they cause their butthole to itch a lot. Whereas roundworms, bigger worms, like if you ever think about like a big worm coming out of somebody's body, these kids who have roundworms, they're terribly sick. They're vomiting, they have terrible diarrhea. So you're going to see this most often in like migrant farm worker communities or people that don't have indoor plumbing. So if you go to the bathroom and the eggs are in your soil and then the kid digs in the soil and eats the soil for whatever reason, then the roundworm eggs will also hatch in their GI tract. So the eggs can survive in the soil for weeks, and usually the kids playing in the soil or digging in the soil and then getting some of that soil in their mouth. And like I said, they tend to be pretty sick with fever, etc. So both roundworms and pinworms are treated with antiparasitics, and it's a lot of education in terms of, the eggs have to get in the mouth to then spread to the GI tract. So hand hygiene, and in terms of roundworms, not playing in the dirt. So poisoning, I think we all know to keep medications away from kids, not letting them have access to household cleaners, etc. And then also just remembering even over-the-counter medications like Tylenol can make you go into liver failure, or Benadryl can kill you. Even though you can buy something without a prescription, you should absolutely not let kids have access to it. So sometimes you can get some information about what the kid might have ingested based on what their vomit smells like. I don't think that you need to memorize this chart, but I would be aware that certain, characteristics of the vomit, like the smell, could give somebody like poison control or someone that specializes in toxicology information about what the kid ate if you don't have any idea what they could have consumed. So, I would encourage all parents to have poison control phone number on their refrigerator. If kids get into anything, poison control is a great resource. They can tell you, follow in a logarithm, be like, this kid really needs to go to the emergency department, or you can stay home, or whatever. So poison control is awesome, and they're there 24 hours a day. It's always the same number throughout the United States. Sometimes if you go to the emergency department, they can do activated charcoal or gastric lavage. So activated charcoal, you consume the charcoal usually through an NG tube, and it binds the substance, and then you can remove it. And gastric lavage is you're going to be, instilling fluid in and then sucking it out. So you never want to have parents do anything like this at home. This would be strictly in the hospital. And if it's been more than an hour since they ingested something, both of these are not effective, because by that point it's already moved out of the stomach. And I talked about this, that it's not just prescription medications. A lot of over-the-counter medications can be really harmful if taken in high doses. So, these are a whole list of things that kids can ingest. So it's not always medications. It could be alcohol. It could be lead. How do kids get access to lead usually?
Pencils.
Yeah, the lead-based paint. So if they live in an older home that has chipping paint, they could, eat a poisonous plant. They could be bitten by a snake or an insect. So there's all sorts of ways that children could be poisoned. And, you just have to monitor them and kind of keep them out of harm's way as much as possible. So why do we worry about lead poisoning? What's the potential thing that could happen if a child has too much lead in their body?
Developmental delays, cognitive brain damage.
Brain damage. It can cause permanent brain damage and mental retardation. So it is something that you really need to be aware of. And like I said, it's usually in the older homes where they have lead-based paint that was used, and they're eating some of the lead-based paint chips. So it usually is pretty mild. They might just be kind of irritable, weak. They might have anemia. And then later stages is where you really see the nervous system involvement. So you normally screen for lead poisoning in outpatient clinics, and you can do a blood test to see what their lead level is. So poisoning, and also, including things like ingesting lead, but then also kids can they can just swallow random things. So foreign body aspiration. What sorts of things? Coins, beans, small parts of toys, whatever you can think of, a kid could probably swallow it. So most of the time it's okay. Like 80% of foreign bodies that are ingested, it passes to the GI tract without any problems. But it can be a problem. So you need to make sure that they're able to swallow okay, they're not having a hard time breathing. And you don't want parents to try to push it out with laxatives or anything like that. You do frequently ask them to monitor their stool if they tell you that they swallowed something, so that you know that it came out. So, you know, as a nurse, you need to be able to differentiate between something that they swallowed that's causing a problem and something they swallowed that's not really causing a problem. And to be aware, usually they just pass it through their GI tract. But if they're having a hard time swallowing or a hard time breathing, they definitely need to be seen in the emergency department. Okay. And we took a little bit more time, so I'm just going to go ahead and pull up your Kahoot instead of you guys having you guys do some more discussion questions. Ask, because I know it's in your Kahoot. Do you think that like something like laundry detergent is harmful, or is it not harmful? Like, what sorts of things would you immediately refer them to the emergency department if they swallowed?
Laundry detergent, definitely.
Laundry detergent, definitely. Yeah. So in those laundry detergent pods from Tide and stuff like that, they can really damage the esophagus. So whenever you're talking about ingestion with kids, I tell students that you always want to err on the side of caution. Like, you're not hurting anything by sending them into the emergency room, because parents sometimes are like, no, I think he's okay. But if like it's a caustic chemical at all that can cause damage to their airway or their esophagus, you really want them to come into the emergency room. All right, here's your Kahoot for the GI tract. So which finding in a newborn is suggested of transesophageal fistula? Failure to pass meconium, palpable mass in the sternal area, visible peristalsis across the abdomen, or choking on the first feed? All right, so there are a couple that are failure to pass meconium, but that's not the fistula. What are the two that we talked about that are failure to pass meconium in the first 24 hours? You
That
remember?
little round hard thing at the top of the
The anus
right below the
perforated.
stomach.
And perforate anus is one of them. Very, very good. And there's one more.
It's an
Stenosis.
Hirschsprung's. So imperforate anus and Hirschsprung's disease are both associated with failure to pass meconium. So choking on first feeding, so a transesophageal fistula, there's a connection between the trachea and the esophagus. So when they eat, some of the formula falls into their lungs, so they tend to choke on their first feed. This visible or the palpable mass, there's a right upper quadrant mass that's associated with pyloric stenosis. And we didn't talk about visible peristalsis across the abdomen. Okay, next one. A child is brought to the clinic with vomiting for the past 2 days. What acid-base imbalance would the nurse expect? an alkalosis, an acidosis, a hyperkalemia, or a hypernatremia? All right, so very good. So vomiting, alkalosis, diarrhea, acidosis. Very nice. So the nurse is interviewing parents of an infant with pyloric stenosis. What would the nurse expect the parents to report? Constipation, projectile vomiting, poor appetite, or diarrhea? All right, very good. So this is the projectile vomiting. That's the classic symptom of pyloric stenosis. So what instructions will the nurse give to the parents about preventing the spread of pinworms? Keep the child's nails short, dress the child in loose-fitting underwear, clean the bathroom with a bleach solution, or wash the bed linens in cold water. Yeah, so this is the nail short because they have to get the eggs in their GI tract to get the infection. So a 2-year-old child experiences constipation frequently. Which food would the nurse recommend? Cooked vegetables, pretzels, whole grain cereal, or yogurt? All right. So the cooked vegetables, they don't have, they kind of, you cook the fiber out of the vegetable. So cooked vegetables are not the best answer. Raw vegetables would have been good, but not cooked vegetables. Pretzels, there's refined flour. Yogurt doesn't help, but whole grain cereal, this is like a good solid whole grain, can help with constipation. So a mother calls the PCP office because her child swallowed dishwashing detergent. What's the most appropriate action? Induce vomiting by giving the child syrup of Iapec, give the child activated charcoal mixed with juice, have the child drink milk to soothe the mucous membranes, or bring the kid into the emergency department. So very good. Yeah, you're not gonna have the mom do any of these things at home. The emergency department can decide. And then, soothing the mucous membranes isn't going to really help them if they've swallowed something toxic. So you do want to have them come into the emergency department. So the nurse has reviewed dietary restrictions for celiac disease. Which grain will the nurse advise that the child can eat? Wheat, rice, barley, or oats? All right, so of all of those things, the only thing they can eat is rice. The rest of them contain gluten. So why are infants more vulnerable to fluid and electrolyte imbalances than adults? A greater percentage of the body is extracellular, body water is extracellular, water needs and losses per kilogram are lower than adults, they have a smaller body surface area, or they have a slower metabolic rate. All right, so they actually have a larger body surface area than adults, and they have more of their water is extracellular. So they lose more fluid through their skin. All right, last one. It's kind of a tricky one. So an infant has dehydration, has a pH of 7.32, a PaCO2 of 40, and a bicarb of 21. How would you interpret that? Is that a respiratory alkalosis, a metabolic acidosis, a metabolic alkalosis, or a respiratory acidosis? All right, pretty good. So we'll start off with the pH. That 7.32, is that high, low, or normal?
Low.
It's low. So if it's low, then it's going to be an acidosis. So then you would be down to either metabolic or respiratory because it's less than 7.35. So you know it's an acidosis. And then the PaCO2 of 40, is that high, low, or normal?
40 to
It's
60,
high.
so normal, right?
It's normal, 35 to 45. So that's normal. Yes.
40.
And then the bicarb, is that high, low, or normal?
It's low.
Yeah. So that's a metabolic acidosis. Do you think if it's a metabolic acidosis, do you think the kid has vomiting or diarrhea?
Diarrhea.
Diarrhea. You guys are so smart. All right. So good job, you guys. I will post the quiz. I'm sorry. I'll post the Kahoot in the announcement if you want to practice it. The last thing that you guys have to do is the quiz. So why don't you go ahead and take another 5-6 minute break, come back a little bit after 11, and when you come back, your quiz will be ready for you to take.
Professor Brunel?
Okay, so as you guys come back, go ahead and flip your camera on. You might have to, if you were logged into Fortis, you might have to log out and then log back in into the Canvas shell. But when you come back in, flip your camera on and then let me know if you're not able to see it for some reason.
Are we starting it now?
Yeah, if you're back and your camera's on, the only person who's not on is Chris Jones. So Keandra, if you see it, you're welcome to go ahead and start. And then when you're done, you can go ahead and just log off. It's the end of class. Oh, thanks, Chris. I see your camera now. Yeah, Yelenia just walked away, but everyone else can go ahead and start.
Once we done a quiz, we can leave.
Yes, you can go ahead and log off.
Thank you. Have a good day.
Thank you. Have a good day.
Hey Gladys, are you still taking the quiz? Hey Gladys, if you're still on, could you please let me know if you're taking the quiz? Gladys, hi. Gladys, if you can hear me, please let me know that you're still here. Okay, Gladys, so I'm going to go ahead and end class because you've had the 15 minutes to take your quiz. So I'm going to give it a 0. I'm going to record it as a 0, and I'm going to go ahead and log off and end this Zoom. So I hope everything's okay.